Next, you would test the nerves. Along the anterior aspect of the forearm, there's the carpal tunnel, which houses the median nerve, and the flexor tendons. The median nerve innervates the thumb, the index, the long, and the radial half of the ring finger. Along with the median nerve, the flexor tendons to the digits and the thumb runs in the carpal tunnel. And the carpal tunnel runs from the distal flexion crease of the wrist to Catlin's cardinal line, which is from the thumb and index web space to the hook of the hamate. The flexor retinaculum forms the roof of the carpal tunnel. To test the median nerve, you can use Snell's test, which is tapping along the median nerve. And if it's positive, the patient will feel tingling in the tips of the fingers. You can also do the carpal compression test, which is where you place pressure over the median nerve while flexing the wrist. And a positive sign, again, is tingling or numbness at the fingers. There's also Guillen's canal, which is bounded by the pisiform, the hamate, and the volar carpal ligament. The ulnar nerve and the ulnar artery run through it. You can do Snell's test over the ulnar nerve and also the compression test over the ulnar nerve, which would elicit a response to the ulnar and radial side of the little finger and the ulnar side of the ring finger, which are innervated by the ulnar nerve. When examining the patient, you also want to look for wrist instability by doing the Watson's scaphoid shift test, which is to check for any periscaphoid arthritis or scaphoid lunate instability. To test this, you have the elbow on the table and the palm facing outward and palpate the scaphoid tubercle while going from an ulnarly deviated to radial deviated wrist, while slowly releasing the pressure on the scaphoid, feeling for a pop or jolt. If you suspect mid-carpal instability or lunotriquetral interosseous ligament instability, you would do the Lichtman's catch-up clunk test, where you move again from a radial to ulnar deviation back and forth, feeling for a clunk in the wrist. The ulnar nerve runs from the medial arm, posteriorly around the medial epicondyle and area of the cubital tunnel, and it splits between flexor carpi ulnaris and then goes down to the hand. It can be pinched from anywhere 10 centimeters proximal to the medial epicondyle to 6 to 7 centimeters distal. Patients with cubital tunnel syndrome have symptoms with elbow flexion or tapping over the nerve. Some patients' ulnar nerve may snap over the epicondyle as well. Patients with cubital tunnel or ulnar nerve symptoms complain of numbness on the dorsal part of their forearm and hand, innervated by the ulnar nerve if compression is at the level of the elbow. If compression is at the wrist, there should be normal sensation in the dorsal part of the hand innervated by the ulnar nerve because there's a branching of the ulnar nerve, but there might be numbness on the palmar ulnar aspect. With severe ulnar nerve symptoms, there's maybe involvement of the intrinsic muscles of the hands, so they would be unable to cross their fingers. To test key pin strength of the first dorsal interosseous and the adductor pollicis, you place a piece of paper in between the thumb and index and ask them to pull. Patients with abnormal innervation will flex the thumb, eliciting a positive Frohman sign. Patients with intrinsic involvement have drifting of the little finger, so they cannot bring it into adduction, which is a positive Wartenberg sign. Patients with carpal tunnel syndrome have involvement of the thenar muscles. Their flexor pollicis brevis will also be weak, and they may have atrophy in the region of the thenar eminence. You test this by bringing the hand into opposition and asking the patient to push their fingers while palpating the thenar eminence for weakness. Patients with carpal metacarpal arthritis of the thumb will complain of pain or swelling in this region. To test this, you would do the grind test where you move the thumb in a circle, grinding the metacarpal into the trapezium, which will cause discomfort. Patients with ligament injury of the fingers, such as gamekeeper's thumb, where the ulnar collateral ligament has been disrupted, will help laxity. So you test this by supporting the metacarpal of the thumb with one hand and radially and ulnarly deviating the thumb. Each of the 4 digits have 2 flexor tendons. The flexor digitorum superficialis, which flexes the proximal interphalangeal joint, and the flexor digitorum profundus, which flexes the distal interphalangeal joints. The FDS and FDP each have 4 muscle abilities. You test this by keeping the other digits in extension while flexing each finger. So to test the flexor digitorum superficialis, you flex each finger. And then to test the FDP, you flex the tip of each finger. With radial nerve palsy, the extensors aren't functioning, so the patient will have wrist drop. They also can't bring their wrist into extension. They can't bring their fingers and thumb up, and they can't bring their thumb toward their other fingers. To test, you would have the palm facing down and ask them to bring the wrist into hyperextension, the thumb into extension, and adduction toward the other fingers. To isolate the extensor digitorum, which are the long extensors innervated by the radial nerve, the patient flexes the fingers and extends the MP joint. Patients with radial nerve palsy can bring their hands slightly up with the fingers extended and the MPs slightly flexed because of the intrinsic muscles of the hand innervated by the median and ulnar nerve. So therefore you also test with the palm facing down and on a surface, fingers extended, and ask them to bring the thumb up and over toward the index finger. Patients with ulnar nerve palsy will have clawing of the little finger and the ring finger, which is hyperextension of the MPs and flexion of the IP. In Boutonniere's deformity, there is flexion of the MP joint, the PIP joint, and hyperextension of the DIP joint. And this is due to a laceration of the central slit which inserts at the base of the middle phalanx. So they are unable to extend at the PIP joint. The Swan-Neck's deformity, you have hyperextension at the PIP and flexion at the DIP due to a laceration of the lateral bands which inserts up to the base of the distal phalanx. So they are unable to extend at the DIP joint. When examining patients with suspected finger fractures, you look for the nail plane. If the finger is twisted out of the plane, there is a rotational deformity, which indicates a possible fracture or dislocation along that axis. For metacarpal fractures, you look for flexion deformity. You flex the MPs and the IPs. If you can see all the metacarpal heads, there is likely no fracture. If a metacarpal is missing, you may suspect a fracture in the finger or flexion deformity of the metacarpal. To test sensation to the fingertips, you can use the static 2-point discrimination test or the dynamic 2-point discrimination test. So you bend a paper clip to make it between 5 to 8 millimeters apart and touch the fingertips enough just to blanch the skin to see if a person can delineate 1 or 2 points. A person's sensation to the fingertip is considered normal if the width is less than 8 millimeters. If it is more, then an abnormality is indicated. To test the reflexes, you can test the biceps, the brachioradialis, and the triceps.